Hey, let me just see. I didn't see any questions on the chat line, so zero. I've taken a bit of your time for the second case.
It's fine, don't worry. I'll just make sure I can share my screen. Now then, I'm gonna. It's always an interesting thing trying to share things, but let me share that and put this across. Can you see my screen?
Yep, we can see it.
Okay, so I'm going to present a case which perhaps is a little which perhaps a little bit more common, and it highlights some of the issues we have with dealing with patients with ventricular arrhythmia. So this is an old case, but it was easily available and it has some nice points to demonstrate. So just checking, actually, the slide change.
Yes, it's changing.
Okay.
79-year-old female.
Brilliant. So 79-year-olds haven't really been under the medical team at all. Her husband had passed away, and in July she got admitted with this vague unwell episode. I said no troponin was done, and I think it might become relevant a little bit later. So she was sent home. This was her ECG, which you can see is in sinus rhythm, and it doesn't really strike anything particularly obvious at this point of view. The computer says that it can't rule out an inferior infarct, but sometimes you do get these, depending on where the ECG is positioned, you might see some axis change in axis, but it didn't look like anything spectacular. So her story heats up in September when she felt unwell, called the ambulance, and presents to the emergency department extremely unwell, hypotensive, with a heart rate of 200 beats a minute. And this was her 12-lead ECG. So I guess for those who are looking to interpret ECGs or trying to figure out where things are coming from, it's clearly a broad complex tachycardia here. There might be some AV dissociation here. These little P waves, they would suggest broad complex tachycardia in an elderly patient. You've got to be thinking about ventricular tachycardia unless proven otherwise, because that's the safest sort of thing to do. So she is cardioverted, and then further investigations takes place. But I just want to spend a little bit of time looking at this ECG. You can see when patients are really sick, you're not going to get high quality ECGs because they're hypotensive, they're moving around. So you've got to take what you can. And so the first question we sort of ask is, where is this VT coming from? This is a patient who has never had any problems before, and she presents with a broad complex tachycardia. So let's have a look, assuming that this is VT. You have got a right bundle branch block morphology, so V1 is positive, and therefore that suggests it is left ventricular. So it's just simple. If it's right ventricular, you'll start off with a left bundle branch block morphology. There are exceptions, but let's not go into that at the moment. One of the other things to note here from a VT perspective is AVR is positive. So there are only a couple of circumstances when AVR is positive, including lead transposition and dextrocardia. But if AVR is positive, it should maybe start thinking of whether this is ventricular tachycardia or not. So let's move on to the lead one. So lead one is suggesting that the activation of the ventricle is from lateral to septum. So we've got a left ventricular VT sort of coming somewhere from the left lateral position. Now then, try and get a bit more localization. So look at leads 2, 3, and AVF. Lead 2 is biphasic, but 3 and AVF are positive, suggests that it's probably coming from the sort of base towards the apical side. So we're looking at something that may be basal, maybe a little bit lateral, but certainly coming from the left ventricle. You can also then look at the transition of the lateral leads. There is there isn't positive concordance. Generally, positive concordance is seen with the inferior posterior sort of location, but this change suggests that the activation is coming perhaps somewhere from around the mid lateral ish wall of the left ventricle. Now, one of the things that I've noticed with experience is that in patients, some patients have VT, no matter how hard you stare at the ECG, it may not always take you to the correct position. And I displayed this ECG to a number of experts in the past, and the conclusion was this is some sort of anterior. This is coming from the sort of anterior wall. But anyway, we'll discuss that a bit later. So once she's stable, she has an echocardiogram which shows that there is mild left ventricular impairment, and there are some wall motion abnormalities, basal mid inferior. Somehow the apical cap appears impaired, and you've got to always take some time to review these investigations. And I'll probably show you these things, show you this a little bit later, because often if you think the report is slightly unclear or dodgy, go back, look at the investigations yourself. She then proceeds to have a coronary angiogram, and the interventionist doesn't really find any need to stent, so basically labels the patient as having some moderate coronary artery disease. Now, because she has got some atheroma, she started on a statin, a bit of beta blocker, and aspirin as a first presentation, and she goes ahead and gets implanted an ICD on the basis that she was very unwell. She had she's got coronary disease, she's got some scar, and that was the clinical decision made. So we can discuss on how you would program this particular device a bit later on if there are any questions with them. But I'll leave it as the fact that she got a secondary prevention, a defibrillator, and off she went. So again, presents in November, very anxious, has been a little bit sick, and notices that she gets a jolt, and comes in very fast VT. It was she was in the VF zone, but terminated by ATP, and the patient is extremely anxious. And I've got to make this point here in terms of the guidelines are recommending defibrillators, but you also have to think about the psychological impact of these devices on patients that we put in. They're not without their risk, and some patients can really lose it when they have one or two shocks. So she spends a few days in hospital and gets started on amiodarone, beta blocker increase, and off she goes again. And then she presents very dramatically, getting multiple episodes of VT, getting multiple shocks in succession, and presents in A&E now with a heart rate of 190 beats a minute. Blood pressure is okay, but the device is interrogated, so you've got this very high burden of VT, 17 shocks, and the patient is not too happy and not looking very well. So you've now got this situation where she is in a VT storm. ATP is not working. She's fully loaded with amiodarone. So the question is, what do you do next? So the first thing, I guess, the answer will be take her to the lab. But before you rush this patient into the lab, it's worth pausing while things are being set up. And I think it's important to visually review the investigations. And I kind of do this as a routine, because when I read the report, it's somebody else's interpretation, and you've got to make sure that it's right, that it is correct for your interpretation. So the first thing to look at is the echocardiogram. Now, this was an echocardiogram done at her first admission. You can see here, that's the RV, the LV. And in the two-chamber view, you can see that there is this outpouching coming off the basal inferior wall. And that is quite odd, because why would you suddenly get this aneurysmal area in this region? I don't think there's anything particularly wrong with the apical cap, the ventricle seems to otherwise contract reasonably well. So I then went and had a look at the coronary angiogram, because I wanted to try and explain why this abnormality was present. And when you are trying to interventionally manage VT, to me certainly it's important that you make a distinction between ischemic and non-ischemic VTs, because non-ischemic VTs can be at times terribly depressing, and you may have to consider going epicardial. So it really helps with the management. So the fact is that she has got some coronary disease, but what struck my eye is the AV circ here, which is stumped out. So there has been an acute occlusion of this vessel at some stage, and that relates to the aneurysm you can see on the echocardiogram. And there is a high possibility that on her first presentation, she actually had a small myocardial infarct. And for VT, it's not about large areas of myocardium. You can have a small area of myocardium that participates in VT, but the hemodynamic disturbances you get from that can be pretty severe. So we go into the case knowing what the echocardiogram looks like. So we're going to be investigating and finding this basal segment somewhere in the inferior posterior sort of lateral part of the ventricle, supplied by the stericary, and we go in with the idea that we're dealing with an ischemic rather than a non-ischemic VT. So as this patient enters the lab, at this point in time, the defibrillator is turned off, because there is no point trying to do anything. This VT needs to be terminated. And we take, obviously in the cath lab, we've got a little bit more control over what we're doing. We try and get a reasonable ECG, because we will need this for mapping. And you can see that the morphology here the leads are displayed, lead 1, 2, 3, up to V6. And again, you can see how the QRS transitions, the fact that we're off the septum here, and that the activation is coming from high to low, and this kind of gives you an idea to start off with is where you want to be hunting for. What you don't want is in a sick patient to start just making a map of the whole ventricle. You need to sort of make up your mind that yes, I will collect some general information, but I need to start zoning in to a particular part of the ventricle. The approach to the ventricle, my preferred approach is transeptal. You can see here we've got a quadripolar lead in the right ventricle, and here is the pressure tracing when we then jump into the when we go into the left atrium. You see the left atrial pressures are very high. And I don't normally use contrast in these cases, but I just wanted to make sure I was in the right place. You can see my ablation catheter, my sheath in the left atrium injecting some dye, just making sure that I'm in the left atrium. You can see from the fluorograph, this heart is beating quite fast. So when you're doing a transeptal in VT, there can be a couple of challenges. We do not always have easy access to general anesthesia, but in this case, I managed to convince an anesthetist to come in and do the case with me. But we did it under sort of conscious-ish sedation, which was not fully anesthetized. But if I was going to do a transeptal under general anesthesia, I would stick a TOE probe down because it's useful to use. It's a very useful aid to anatomy. So we get into the atrium, and then start mapping the left ventricle. So I want to show you a couple of signals here, and question what they are. So here is and I'll display these a little bit better before. Here is what we call a nice fractionated signal on the ablation catheter. So the question is, where are we? As one of the points that we discussed earlier on is whether you use a multipolar catheter or go point by point. In this particular case, I chose not to use a multipolar catheter because I wanted to try and get to the signals and ablate. Now there are I don't think there is any right or wrong. You can put a multipolar catheter in, but sometimes I find in this sort of setting where you want to try and speed up things, it can be quicker, but sometimes if it doesn't always work and you need to switch strategy. But the point here was to go in point by point with an ablation catheter. So I am only looking at a few signals, and so we find this signal here. So we are looking to identify the critical isthmus of VT, which tends to which will be between the QRS complex. So that area of the critical isthmus is where if you get a signal there, you refer it as a mid-diastolic potential. So this signal here, the question is, would you ablate? The answer is also we had interaction. The answer is probably not, as this is what looks like an entrance signal. So the if you imagine the VT circuit, the signal, the electrical impulse is entering the critical isthmus at this point and exiting out somewhere else. So no, I'll try and map a little bit more at this point. Sometimes in desperation, you may just want to ablate it to try and see what happens. But in VT, if you want to try and nail the exact spot, then you need to look a little bit harder. So we find this signal here then, and you can see here that it is a very nice long fractionated signal. It encompasses a reasonable amount of the VT cycle length, and it occurs within the mid-diastolic phase of the VT. So you're kind of all excited and saying, should we ablate here or should we do a bit more testing? So we decide, let's entrain this. For those of you who are on the foundation course, we've discussed the concepts of entrainment. And the idea is, one, to capture the tissue and then to measure the post-pacing interval. So here is the pacing spike in the ventricle, and we are trying to measure an impulse here. Unfortunately, there are two problems here. One is that the electrograms are not really visible because they're really small. And secondly, you can clearly see here that we have not captured the ventricle. So this is not entrainment, this is just non-capture. So you've got to be careful when doing these maneuvers that you are getting the right information. Otherwise, if you just take this at face value, you'll say, this is concealed entrainment because the pacing match and the VT match are the same. This is a good site to ablate. Anyway, moving on to the interesting bit. Again, going back at the mid-diastolic potential and applying energy. You can see here energy is being applied. This is the RF and the VT terminating, and one is happy at that point. But that often in ischemic VT isn't enough, because you want to reduce the chances of patients getting VT, and often there is the need to modify the substrate more. Now, what I want to show you here is the VT circuit. So to orientate you, this is the aortic valve here, and behind here, this cutout where this blue line is the mitral valve. This is the region of interest, and you can see here that we've got all the colors of the rainbow localized within this small patch. The yellow point is the AV node. So let's have a look at what's happening at these particular points in this map. If you take the green point here, you can see that this signal is pretty much in the middle of the circuit. If you take the the yellow point here, this looks like it's going in that direction, sort of from yellow to green. And if you then go to the sort of purple points here, this point here, you can see that this is late, and the exit into the ventricle is probably coming from here, which is why the ECG appeared to be exiting more laterally, although the meat was in this sort of posterobasal aneurysm. And that's important to recognize, that that the ECG QRS will tell you about the exit of the VT, but that you do have to hunt for these signals, which will be hidden in the diastolic phase of the VT. So it demonstrates to you nicely how the entrance comes here and the exit of this comes up more laterally, in keeping with what we saw in the on the ECG. So, having identified scar within this area, a cluster of ablation lesions are added on. You can see here we've kind of put some arrows to sort of depict how the VT is going around in this scar and probably exiting out from this side. So this red refers to scar. The rest of the ventricle is purple and relatively healthy. So ablation was performed here to consolidate the lesions. And at the end of the case, at a reasonably aggressive stimulation, we only had some non-sustained VT, at which point the patient had already had enough and we decided to stop. Because of the limited nature of the sort of circuit, the amiodarone was stopped and she was discharged 2 days after her presentation, and actually has remained pretty much VT free for all these years. So I'll end there. I'm not sure how I'm doing with time, Ashley, but I'll stop here.
Yeah, thanks, Muzahir. That was a great case. Did you, just when that patient came back with a VT storm, with the incession, when the patient had like 19 shocks, what was the time frame when you took them to the lab? Did you settle them down with amio first and then take them, or did you take it quite soon?
So that at that stage, the patient was already loaded on oral amiodarone because they'd already come in before.
Okay.
So they were sitting in resus, and then the question is, well, what do we do now? And we were lucky that we got them from resus straight into the lab. So there's no planning, unfortunately, in here, where you say, let's get some imaging, let's do the CT. We don't tend to do CTs or MRIs. We're quite pretty much on the basics of what we can do. Because she was sick, I managed to get an anesthetist because of the to handle the sort of hemodynamic kind of just handle the hemodynamics and provide reassurance, because it takes away that strain away from you, and then you can concentrate on the case.
And just your approach with you normally on the lateral wall, I tend to use the retrograde approach, and then septal go the transeptal route.
Yeah, I try and avoid the artery like the plague. I just feel that with the catheters we have these days, it is usually possible to get where you want to. So I tend to reserve the retrograde approach for the cusp VTs, or if there's something outflow, I'll go there first. And then in these sort of cases, if I'm not getting anywhere, I needed a second access, then I'll do an arterial stick. And what I tend to do is I put a radial line in for hemodynamic monitoring. If I don't have an anesthetist, then I'll just do it myself. And if it's epicardial, you can do an angiogram through that if you need to. But that kind of is a sort of my thinking, because I just don't like the artery and crossing the aortic valve, and then the catheter pings out, and you got to recross again. So it's I guess it's more with preference, isn't it? I'm more comfortable, as I say, puncturing a hole through the heart than puncturing a hole through the artery.
Christy, I know, comments from your side?
Yeah, really nice case, Muzahir. I really enjoyed it. It's a funny scar. I don't see such a focal scar that often. I think the point is well taken, non-ischemic versus ischemic. I also would just add that it's the location of the scar, and it's very often that it's that basal area, or you probably needed the valves so close. You need some kind of inert structure. The other thing that was interesting in the ECG is I thought maybe there was some easy access to the fascicular system, because there was just such a sharp onset to some of those QRSs. And so in that valvular apparatus adjacent to the mitral valve, you're sitting so close to the fascicles, and those are they survive, whereas the myocardium dies. They have a different, metabolism, and they get blood from the endocardium. And so I often find that area, I just don't often see such a discrete area, but it's adjacent to the mitral valve and involving some of the fascicles.
What struck me, Chris, which sort of got me slightly depressed at the start before I reviewed this, is that that lead one was negative.
Yeah.
And then I get a bit worried, because
Yeah.
that suggests to me this is not going to be coming from a standard area. And it's surprising that the scar is fairly, is close to the septum.
Yeah.
Yet the breakout,
there
kids you that it's coming out way more laterally.
Yeah, and we found that with mitral valve reentry. So you just need a little bit of a slow zone there, and it's either going to exit on the septum, or it can exit on the lateral wall, and you just don't otherwise see it. And if you're exiting on either of those, you're probably going to catch the Purkinje. The other thing is it illustrates that defibrillators are not treatment against VT, they're treatment against sudden death. And putting in a defibrillator means we have to do something about the rhythm. Otherwise, the patients are going to get shocked. I also always use a transeptal unless my hands are tied for some reason. And the only thing is going to push me to go retro-aortic would be something in the cusp, or there's some big thrombus on the ICD lead that I worry about crossing over afterwards, because there is data on, even after atrial fibrillation ablation and transeptal puncture, if someone has a pacemaker or defibrillator, there's a high incidence of post-operative stroke, which we think is probably paradoxical. But I do feel you get better. It's easier for me to move the catheter.
Yeah.
And I worry about dislodging a little bit of calcium in the aortic valve in an older patient. You made the point as well, is these patients, she's psychologically scarred, and we get all of them to meet with our therapist so they can get some building blocks in place psychologically so that they can get on with their life. It's a tough one, all those shocks.
There was a question, and this is slightly controversial, is she may have got away without a defibrillator. Because if you say, took her to the lab, you ablated a VT, identify that bit of scar, the LV function was relatively preserved. It is a controversial point I'm putting in here, but there is this whole thing that if we had managed the arrhythmia right from the outset in somebody who's got, albeit structural valve disease, but the LV function is not too bad, and they haven't been in a cardiac arrest situation. I mean, this patient was getting shocked because they had a defibrillator in that was treating it. In terms of balancing between how how you manage it, but I accept the point is in terms of the management, is putting a defibrillator in when somebody is hot with VT is a bad idea. Because it will just keep on going off, and it's important. I think that if she had come de novo with this storm situation, I think would have gone and made sure that she's got no VT, and then put in a defibrillator, either proving that the amiodarone would work, or we'd taken her for catheter ablation. But I think there is this notion sometimes that a defibrillator is, once the defibrillator is in, that's the VT treated, and I think that is kind of important to understand that it's rhythm management. A defibrillator is a backup for for if you really, really, really need it.
Yeah, 100%. I agree. It's an important point. The do you need a defibrillator if, let's say, this wasn't secondary prevention? Because I would put it in the secondary prevention because she presented with sustained VT. But let's say it was primary prevention, or you've had some non-sustained VT. Does she need a defibrillator with preserved EF? The congenital literature would argue we can avoid it because there's a discrete scar, there's a VSD patch, there's an outflow, you can ablate, you can make sure that you've got bidirectional block across the isthmus where the VT was, where it was relying upon. And also there's some data in the ARVC literature, just a little focus of ARVC. Maybe, and it's just a young patient. You don't want to put in a defibrillator yet. I worry about ischemia because we don't know when the next ischemic event is going to be. Yeah.
I mean, I just to slightly digress a bit because this was an interesting case. I had a patient who was having syncope, and he'd had several investigations that were fruitless. ECG normal. He even had, I think he had a MyView scan that was normal. He had a tape that was normal. So he's having these episodes of unprovoked syncope. He ended up getting a loop recorder. And what happened was I was on call and the physiologist came running to the lab saying, "Can you look at this?" And basically, it starts off with this loop recorder ECG looking fairly normal. And then you got ST depression. And then you got some beats of ectopy, and then a run of polymorphic VT, which fizzles itself out back to sinus rhythm. That was really, really bizarre because it just throws this whole notion down that I have an argument with the interventional team that, well, this patient doesn't have pain. They don't need their coronaries, this chest pain equals. So brought the patient in and they had a very tight LAD lesion. They ended up having surgery, and their syncope stopped, and that was it. Now, we had a lot of deliberation about this. Do we give this guy a defibrillator because he's had a fairly life-threatening arrhythmia? I know he's been revascularized, but how much faith does one have in revascularization if it goes? If the patient has, if the graft blocks or something like that happens, what happens? So spoke to him, discussed everything with him, and gave him defibrillator. I don't think he's used it to this day. This case was 10 or so years ago or more. And it was such a rare case, I submitted it to the Lancet as a case review, and they took it. And I was really worried about what the reviewer is going to say about the defibrillator thing. They were actually quite positive about it. The only argument they had is, why did the surgeons put a saphenous stent graft onto the LAD? So it's quite a tricky one because the guidelines will say that if you have been revascularized or you've treated the cause, then you don't need a defibrillator. And I think some of these things are slightly off. You have to go out with guidelines to think about this. Normal ventricle, no scar. What do you do? I find some of these decisions very, very tricky, and I don't know whether you can ever get it absolutely right.
Yeah, that's a really nice case. So you could definitely go either way there. It's interesting though. Lots of people have ischemia, but they don't have polymorphic VT like that.
Yeah.
And, they can have occluded LAD, right coronary, but there's something different with someone's physiology, and it's probably at a channel level where some people are more likely to fibrillate with a little bit of ischemia, and he's demonstrated that. So yeah, that does not fall into the guidelines, but it is one of those just tough cases. Yeah.
Okay, I think we've gone over time, and I think we'll have to call it a day today. Yeah, I think that both talks, I think they were very illustrative. We hope to have these future webinars on every the first Wednesday of every month. And
Yes.
Yeah, Prof, do you want to have the final words to close the session?
Yes, I'm really happy. I'm thrilled by these interesting cases, very high level, which goes starts from clinical to reality to ablation. And I wish that all the audience are getting benefit. We are recording this session, and we can send it to them. And also we can allow them to send us some questions to be answered to their emails to be sent to them. Thank you very much, Muzahir and Ashley and Dr. Clues for this interesting session about the VT ablation. As you said, Ashley, we have a once a month meeting, which is an advanced EP cases, and next month will be our turn. Okay. Thank you, everybody, for attending, and people are saying thank you in the chat box. Thank you.
Thanks, everyone.
Thank you.
Good evening.
Okay, bye.
Thanks for having me.
Bye.
Bye.
Bye.